Good morning and welcome to our monthly webcast. I am Samir Mehta, your moderator, and this morning we are going to take you through another complex coronary intervention involving a bifurcation lesion of the left circumflex. Let me take you to the Cardiac Cath lab where Dr. Sharma and Dr. Kimi are already scrubbed in. Samin, good morning.
Well, good morning with all our team. We welcome our CCC Live global viewers for our case number 65. As you mentioned that we'll go with the bifurcation. It's not a routine large bifurcation, but we'll go through this particular case. And of course, if we can, before we go to the angiogram, if I can go just a little bit history of the patient and with the slides, these are our supporters, the disclosures as usual. Dr. Dangas actually, if he comes, will join. We'll put his disclosures later. Now, this is a 74-year-old patient who presented the last month actually with the new onset of crescendo angina class 3. He also has ischemia, severe inferior and moderate lateral. So he has a high-risk scan, for which he underwent cardiac cath, which revealed 3 vessel disease and normal EF and syntax score of 22. Now, because of syntax score is still less than 23, patient underwent rotational atherectomy and 2 Promus PREMIER DES to the calcified RCA and continued on good medical therapy and still has some angina, and largely because we'll show you why, because of the significant lesion, and now comes back for the intervention of the circumflex. LAD has a lesion, but moderate, but circumflex has multiple lesions with a syntax score of 22, as I mentioned. After the RCA intervention, now the syntax score becomes 17, and our goal is today to take care of this bifurcation lesion, whether use 2 stents or 1 stent, but we'll try to show maybe a planned 2 stent approach, particularly with the complex lesion definition, which I'll show you with the latest one from the definition study, what it is, and use of another device, another balloon called chocolate balloon. Very funny name, but apparently it exists for the peripherals and now has been approved for the coronary also, which has its own mechanism of action, which we'll talk. Now, clearly appropriateness point of view, very high risk, so makes it fully appropriate. Now, about this balloon, which we'll try to show today, is that chocolate balloon, which is made by Tri Medical. It's a nitinol constraining structure and with a unique dilatation, pillows and grooves. Now, what does that mean? That when we inflate the balloon, as you know, the balloon expands at the corners like a dog bone boning effect. Now, clearly because of this design of this balloon, and they call these the pillows, which is the vessel dilatation without cutting or scoring, and the grooves are the stress relief. So key is that you plaque modification, but in a different way, very controlled. Like when we do a cutting balloon, we cut the plaque or with the angiosculpt. But here, this nitinol, the wire will basically just cut, but then let the plaque vertically move, and that is where then it is opposed to the wall by the balloon. So that basically becomes the concept of the pillows and grooves, and reduces dissection and recoil, improve lumen size and fast deflation and inflation technique compared to balloon angioplasty, which we know by the vertical and longitudinal inflation cause a lot of dissection, that with the chocolate balloon have a lower incidence of dissection. And of course, you need to see once it gets to the coronaries and so. So indications basically is that DES is more problematic, particularly the cases where we use the drug-coated balloon. Small vessels, bifurcation, especially ostial lesion, depth contraindication. Key is that you want to have a good stent-like results, but not to put a stent. That the chocolate balloon may help in that situation. And of course, vessel preparation before BVS. And the idea there is that you can have a good results with this balloon compared to our regular PTCA balloon, or I would call it an atherectomy balloon of the cutting balloon and angiosculpt. With that note, Anu is ready to show the case, what it is, and then we'll come back to the 2 points.
So if you see the angiogram, this is his LV function was normal, EDP about 10 today. He had the right coronary required rotational atherectomy and 2 stents, distal RCA from mid RCA almost extending to the proximal. If we see, the stent looks good, and this is his left system. Left main is okay, but circ, where we see the proximal 80-90% lesion extending to the distal, which is about moderate 50-60, and the bifurcation is proximal circ going to the distal circ and involving OM1, which will be Medina 111. But also you see OM1 further down, another 80-90% lesion in that moderate size vessel, and then OM2 further down has another diffuse moderate disease, 70% or so. And this is this LED. LED is small vessel, doesn't reach the apex, about 60% lesion in the mid. And this is the caudal picture. If you can see that truly the proximal circ extending into the distal circ, there is disease. In this view, actually the OM1, the ostium, is still about 50%, but if you see in the RAO view, it looks about 60-70%, but significant disease is further down.
The complexity of the case is not only the bifurcation. Remember, we talk about Medina bifurcation and so, but what about the additional lesion distal to the bifurcation? And this is where in this case is, whether we call it a distal circ or OM1 and OM2, that there are additional lesion distally which also need to be addressed. And that has an important point of the decision making once you put a one stent versus two.
Now also the calcium, you can, I think if you can appreciate, not heavy calcium but a moderate calcium that you can see, which will in a bifurcation case, how do you handle that?
Samin, before you start your formal presentation, I have been besieged by questions regarding the suddenly emerging new role of antiplatelet drugs as was evident from the presentation of Dr. Laura Mori at AHA. Any comments to that?
Well, I can tell you one thing, that if cardiology has been successful in confusing the community, this AHA presentation of the depth duration has really confused everyone. Because
including you?
Including me. I thought that we are going back, decreasing the duration, and now turns out to be that longer antiplatelet therapy may not work through your stent thrombosis. It's working through by decreasing your primary events or secondary events in the CAD patient. So like you're doing it for primary and secondary prevention of the native vessel, the plaque rupture and causing lower myocardial infarction. But I think what we'll do is I'll include them in the next month's our discussion.
But a quick follow-up, how does that impact BVS?
Yeah, I would say that because they did not show the true interaction. We knew the DAPT trial will be positive for the 12 months versus 30 months, largely because of the majority or more than half were the first generation stent. We need to see the interaction with the second generation stent, and if it's truly there, then maybe in selected cases we need to, patients particularly with the frequent coronary events, maybe you should continue 3 years or even longer. So that we need to see. But clearly, on the contrary, the ISR safe showed that 6 months versus 12 months, you pay no penalty of decreasing the DAP duration in the current generation DES to 6 months. Okay, so with that note, I think we go quickly while Dr. Keeney, is there any plan for the IVUS here in this case, although it's a mild to moderate calcium only? So we quickly go through these two important points, and as we said that we always try to do an update of the depth duration. I'll do next month coming from AHA, and then we talk about the bifurcation lesion PCI and update on revascularization in diabetic patients. Bifurcation lesion, various techniques which have been shown, and we know that DK crush, which is the double kissing crush, has been shown to decrease restenosis compared to conventional provisional stenting in the DK crush 1, 2, 3, 4 trials. And issue always remain, what do you do for the side branch? It looks many times very narrow, but do you do a PTCA and not? It's always Nordic bifurcation 3 did show that routine PTCA of the side branch is not necessary, but many times you have a large side branch and you plan to do a stenting, should you routinely do the stent? Now this is actually a very interesting data. As you can see here, that 38% of the tight lesion, which we call more than 75%, has FFR of less than 0.75, not even 0.8, 0.75. But clearly that higher, and many of these tight lesions have a good FFR. So basically, concept is that if you have a good FFR or more than 0.8, you can leave those lesions alone. So those are the functionally non-significant. Now, incorporating that, is in the DK Crush 6, where they randomize the comparison of FFR guided or angiographic guided provisional stenting for true coronary bifurcation lesion. This is from the DK Crush groups, which have shown to be beneficial. And basically they divided about 160 group patients in each group, FFR versus angio group. And of course, they did a main vessel stenting, jail the wire. And then of course, in the PTCA group, what we do, that basically if there is a more than 70% diameter stenosis of the side branch or dissection or TIMI less than TIMI 3 flow, then you do a kissing balloon dilatation. It doesn't make it good, then you do the stent of the side branch. In FFR group, if you put a wire in, if it is less than 0.8, then you do a kissing balloon and you repeat again FFR and still have a less than 0.8, then you stent it. And of course, 1 year outcome. Now, as you can see, there is a lot of crossover, lot of very complex study, but I really had to congratulate the authors to do 300 plus cases using this technique and 160 being with the FFR. And overall, basically, side branch PCI was done in just about 60% of cases in both the groups. Slight difference in the stenting, 26%, 38%. So slightly more stenting in the PTCA group which happened. But what about the 1 year outcome? As you can see, identical. So you went through this very complex process of FFR guided or angiographic guided, and you're exactly identical outcome of the MI-TVR, stent thrombosis and MACE. So therefore, the more important issue is where was the stenosis when these patients came back in this the 6% of group. They actually define it in the proximal main vessel, distal main vessel or side branch, and I put it in the very simple slide. As you can see here, that in terms of the restenosis, when you do a angiographic guided, that you have more distal vessel, main vessel restenosis. But look at the side branch. FFR kind of paid the price of higher restenosis if you let those lesions alone, even based on the 0.8. Provided some of the cases you could not cross. But C is that leaving the lesion based on the FFR, you are twice the percent of restenosis compared to you did a PTCA, because slightly higher patient require stenting in the angio group. So therefore, I would say that overall, what we learned from the DK Crush 6, that FFR has no value, rather it's a more tedious in comparison. So just go what we have been doing clinically. Now the second part, the paper I really wanted to discuss the study is the definition study. Remember, we always talk about, should we put the 1 stent, should we put a 2 stents, which patient going to need a 2 or 1. This is again from the same group who would have done the DK Crush studies, and what they did is they analyzed their own data in large number of patients, over 4,000 or 5,000 cases, and then they say, well, can we divide these cases based on the simple or complex? And if they are simple, then you just do a provisional stenting. But if you are complex, probably you should do a 2 stent approach. And this is very important. They have a clear definition of the criteria, which as you see here, the major and minor, basically more than 70% stenosis in the distal left main, and with the non-left main, which is the side branch being the 90%, and the minor criteria with the multiple lesions, the bifurcation angle, main vessel 2.5 or thrombus containing lesion or lesion length of more than 25 millimeter in the side branch. And they really saw, revealed that in their analysis training group of 1,500 patients, that major and minor really predicted the outcome with a very high degree of sensitivity and specificity. So then they prospectively enrolled about 3,800 patients to this criteria of the simple and complex, and basically the outcomes were clear. Complex cases have an in-hospital outcome and 1 year outcome much higher, almost double in every part of the MI, PVR, MACE and stent thrombosis compared to the simple group. But that we understand, simple. But more important was, in this 1,100 patients of the complex group, you do a 2 stent strategy or 1 stent strategy. Again, remember, this is the center which is very well known for 2 stent strategy. And I would say that very few data to support 2 stent strategy. And here is one. That is, in complex cases defined by the definition study, that if you have a complex case, half of them got the 2 stent, half got the provisional stent, but clearly having a 2 stent approach was associated with a lower event rate, non-statistically significant, but trend toward lower stent, lower rate, maybe lower even myocardial infarction. So there seems to be, in a complex case, you go with a planned 2 stent strategy, will do better compared to one stent study. Now then there is another concept people keep talking about, the drug-coated balloon. As you know, the drug-coated balloon now has been approved for periphery. Clinical trials of the drug-coated balloon in the coronaries are not being done in the United States, but it's available outside. Very expensive device. The question is, can we compare this with our drug-coated stent, which is the paclitaxel coated balloon, compared with the DES? And this is the Babylon study presented about a small number of patients, about 100, but clearly showed the drug-coated balloon or drug-eluting paclitaxel drug-eluting balloon is inferior to drug-eluting stent. So even for the side branch, you can see here, so clearly that there, in my opinion, drug-eluting balloon may be good for some cases of instant restenosis, but still need to prove against DES for the main branch or side branch. The second quickly is the revascularization diabetic. All studies after studies have shown that diabetic patients have a bad outcome. No surprise. This is the 10-year data of the MASS2, which compared the medical therapy, PCI or cabbage. That clearly you can see that whether it's any group, whether PCI or cabbage, there is a lower event rate in the non-diabetic, lower mortality in non-diabetic versus diabetic. Clearly in the patient with the PCI group, the much difference in the diabetic versus non-diabetic, which we knew. Then there is another study called VA CARDS, which was prematurely terminated after 200 patients, did show higher mortality with the PCI, but again higher MI rate with the cabbage group, but no difference in TLR, but very short-term study of the small number of cases. But we all know the landmark trial of the Freedom, which showed that there is almost the 8% reduction in the MACE of death, MI, and stroke at 5 years from 26.6 to 18.7, and largely driven by 5% lower mortality in the cabbage group compared to PCI. But yes, higher stroke rate, and the 1-year TVR almost was 1/3 in the cabbage group compared to PCI. But remember, this was done with the paclitaxel coated or sirolimus eluting stent. So first generation stent, and this leads to this graph. But you see, after 3 years, actually, only about half of these patients have a clear, exact follow-up. But more importantly, that now we have the newer generation stent, which compared to the first generation of the paclitaxel eluting stent, this is with the everolimus eluting, lower stent thrombosis, lower myocardial infarction, split 5 trial. Then we assess diabetes, same comparing against sirolimus eluting stent, lower MACE rate and lower MI rate. And so then ISAR left main 2 study comparing jetrolimus to everolimus, again kind of statistically lower, non-statistically lower event rate with everolimus. So what the data of the Freedom would have been if we use the newer generation stent. And this is actually a very nice article with published in Circulation Intervention, is that can the newer generation DES bridge this gap in the diabetic patient? And what they did, it is the network comparison of all the trials of the cabbage, PCI, POBA, BMS, SES, first generation, then cobalt chromium, and basically compared them with each group, with the PCI, with the cabbage being the standard, making it a unity. And then, of course, all part of the death, MI, stroke, repeat revascularization compared. And if you see here, that all cause mortality. Now, clearly the cabbage in all group, when you compare with the POVA, BMS, first generation DES, it's to the right of the midline. But once you get to the cobalt chromium EES, it's like the hazard ratio is almost at 1. So clearly seems to be that if you would have done with the cobalt chromium, the Freedom trial, maybe there would not have been any difference in mortality. Again, it is just the analysis comparison of various independent trial, but not a cross comparison. Now, if you go with the outcomes with the myocardial infarction, you can see here lower MI with the cobalt chromium, and of course the stroke rate we always knew was lower with the PCI. Now, repeat revascularization, while of course all PCI group have higher repeat revascularization, but again cobalt chromium close to the unity. So seems to be that newer generation stent might do better, and they actually have the final sensitivity analysis against specifying even a large number of patients kind of complexity. If you take account, still the cobalt chromium may come beneficial compared to the cabbage. So therefore, if I plot the data which we have, that we have 1/3 reduction in the MI and mortality, and of course the slightly decrease in the stroke rate. With the newer DES, I can say the curves could have been with the cobalt chromium EES superimposed with the cabbage. Clearly, this is not, I don't want to provoke any, but I just say based on the data, and that's this review article really makes it a point that second generation stent may really fill in the gap. You want to start engaging? Yeah, and then clearly the other point I was actually looking for, the freedom trial. What about the insulin versus non-insulin? As we expect that insulin patients have a higher event rate, whether they're diabetic or whether you go cabbage or PCI. And here is the showing the patients in the non-insulin treated on the left side and insulin treated on the right side, and you clearly see that insulin treatment has a higher event rate, but for both PCI and cabbage, there's no separate interaction. So it's not that the patient with insulin treated goes for cabbage have a lower event rate. The outcome or the difference which we have is similar for both of them. Now, very important data would be the freedom follow-on registry, which is just starting. That will be a additional 3-year follow-up beyond the 5-year. Which we have, and patients who are in the freedom will be called and go through the primary endpoint again. But more important is mortality. That are we going to see the difference in mortality in these patients, particularly in the cabbage patient? We know the event starts after 5 years, while PCI event starts maybe after within few months. So clearly this freedom follow-on registry will help a long way to answer many of these questions about whether is there a truly difference in a long-term difference in PCI versus cabbage, even with the first generation stent. But clearly it seems to be the data-wise that the second generation or newer generation stent can fill in this gap. And how will it, we say that, how that happen? I mean, very simple. You'll have a lower myocardial infarction and you'll have lower stent thrombosis. And to me, both those events will work in favor of causing the lower mortality, because that was the biggest difference. 5% mortality difference in the PCI with the first generation DES paclitaxel there compared to cabbage. And if we extrapolate the available data of the everolimus eluting stent, the Zions and Promus, and that clearly the difference to me will narrow, could even be identical. With that note, I'll stop here, and Anu is ready to take a guide picture and start the work.
Samin, excellent review of two pertinent issues. There are a few follow-up comments I have and a couple of questions which I'll continue asking. Based on, in many ways, without calling it definition, and as you were presenting the data from there, I kept thinking about the bifurcation cases we've done. I think you've almost had the same strategy, that for complex cases you've been using a strategy of 2 stents, whereas the simple ones we've been doing provisional.
Absolutely. And now we actually have the data to support that not every case the 2 stent is bad, and also not every case needs the 2 stent. Now, in the simple group, when they compared the 2 stent versus 1 stent, actually there was slightly harm of the 2 stent strategy, which I did not show because that was not statistically significant. But clearly the trend was that once you have a complex and you do 1 stent, you actually have more trouble.
I'm sure you've conducted a more detailed breakdown of your own bifurcation series. What percentage of your cases are the DK crush now?
Yeah, well, actually, DK crush we still use very little.
Yeah, that's what I thought.
Yeah, our
more SKS, no?
Yeah, so SKS, or whether we use a T stent or kind of mini crush and so forth. So that kind of a more our working strategy in majority of our patients. So that makes still about 25%, and same thing that 25-30%. Same thing in the in that expert center of the 3600, the complex group was about 1100. So was about just close to 1/3 or 30%.
Right. Anu, I'm sure your plan is going to be doing the distal lesion in the second OMB first.
Yeah, I think the distal lesion of OM1, we treat that.
Yeah, right.
Then the discussion will be how we take care of the bifurcation.
Excellent.
Wiring wise, same. You always take any 2. I mean, usually the side branch. If you are thinking of provisional, go with a side branch, which is usually a glide wire, which you can leave in the side branch if you're going to stent across, if your strategy is to leave the wire. So the plan, the important discussion here would be what is the stenting strategy that we want to use in this case. So definitely I think once we take care of the OM1 lesion, which is 90%, that's done. The question is, do we just do we call this a simple bifurcation or a complex bifurcation?
No,
then we can decide what's the plan.
But this is a complex bifurcation by our definition study. Although there are many studies, but I think that seems to be very good. But I don't know whether this is actually even complex of the complex, because besides your bifurcation, you have 2 additional lesions in each vessel, which you need to address first before you come to the bifurcation.
But then we can only take care of the OM1. I think OM2 you can just decide on medical therapy, the distal lesion.
Okay.
And then coming to the bifurcation itself, if you start proximal circ going into OM1, you need a long stent, since there is a moderate disease after the bifurcation which you need to take care. So I think one long stent will take care of that. Question is, do you just want to balloon the distal circ and consider stenting across, or you just have to decide that once you take care of the distal circ PTCA, then do we are with 7 French guide, so yeah.
That is, Anu, that was the first question which had come specifically for you. Is this a 7 French, and do you almost always recommend a 7 French?
If you are thinking, if you are thinking of double stent, which I always teach our fellows, is that once you have a bifurcation and you know there is no access problem, I mean our case is femoral and we know there is no groin issues, I always tell them go with 7 French. Now if there is an access problem and you can only do with 6 French, can we do it? I think 2.5 stents can go through a 6 French, but when we are going 3.0 and 3.5, 2 stents through a 6 French becomes problematic. Then you can do bifurcation, but you cannot do modified T, mini crush, V stenting, SKS, where you are placing 2 stents at the same time. You can do serial stenting. That means you take the side branch, stent it, then you go with the main branch stent and stent it. But so ideally, to do everything comfortably, you have to have 7 French.
Excellent.
We have chocolate balloon 2.5, 20.
So Samin, chocolate is because the color is chocolate?
No, we are just going to predilate. No, the color is not chocolate.
Then why did they get so fascinated by chocolate?
The distal.
Yeah, distal. 2.5.
Not with 20. You don't need 20 stand there.
You'll need a long stent there.
No. Get us a 2.512. 2 or 12.
So Samin, has somebody conducted a research as to why it's called chocolate balloon?
Yeah, I did ask them that question. I don't know what answer I got.
All right.
What was the reason for calling it chocolate? I think I think those the nitinol cage, they look like a chocolate bar.
Ah, all right.
Maybe I just made it up.
Well,
Yeah, but a very funny name.
As good an explanation as even the company would have it.
Yes.
Maybe it is not. You see how the nitinol bar is, it looks like a Hershey chocolate bar.
You have to pull the wire.
So right now we are going to go with the PTCA with the 2.012, and then we can stent that, and then we decide with the bifurcation. Yeah, right? Okay.
Pull back, yeah,
go
go
up. Yeah. You want what's the stenting?
Promus, all from.
Okay. Then you want a 16, 2.5, 16, or 2.25. Go, crack it. 16.
Yeah, 2.25 is okay.
2.25.
Yeah.
2.25, 16.
And back in the guide.
Yeah.
So that was a regular balloon or the chocolate?
Yeah, regular balloon.
Mini track.
You want a 16?
No, with the 20. I would go 20, 24.
Then you'll be like a full metal
Yeah, but
jacket,
that's
entire vessel.
Yeah. 2.25,
20 he wants,
20.
20.
There's mild disease distally. Clearly, the always question comes with the DES, do you still go with a short stent versus a longer stent? I try to say that idea should be that you cover one, the area you have pre-dilated, secondly, the disease segment. Because disease segment, and you have the fall off of the drug really then they come back with the edge restenosis. So we are deciding 2.25, 20 millimeter Promus PREMIER for that OM branch. The patient has a Promus in the right coronary.
I thought that could have easily taken a 2.5.
No.
It's a lot of disease,
Okay.
diffuse
Yeah.
disease.
Samin,
But I mean, if necessary, we can post
that's
dilate.
no big issue.
No, it's a
Samin, very provocative. Okay, here is the challenge,
Yep.
Didn't think about this.
and that's your explanation. Whether we call it a simple bifurcating or a complex, here it
The
is.
balloon again. You dilate that area.
No, because we did not pre-dilate that area.
That segment, yeah.
Can you ask a deep breath or no? Difficult. Good. Done.
You always pull back and try to go with the speed. No, too far.
No, we don't want to. Wait. You're going to leave a gap, right?
Yeah, that's
I
fine.
think we are going to leave a gap.
But pull back a little more.
I think you're good now. Yeah.
Okay, go.
You're going to post. See now? Even
Right.
the 2 to
No,
5.
if
This
that
is
should
at
be, we can
12,
always
14,
post
yeah.
dilate here. 14. Now question.
Okay, now you get the chocolate balloon. Even then, 20 is too long. I wanted a 10.
For what? No, you
Chocolate.
can do from proximal to the OM. I
No,
mean,
but
this is
then you don't want
that's
to
okay.
use
You-
the same balloon in
No.
the other branch.
That one, because point is we put a mini crest, one stent distally and one in the OM. Bigger, longer stent in the OM. Right?
If you have to do that, 20 is too long there.
No, but from proximal to that area.
No, I think 10 would have been better.
Yeah, we are 10.
Give the 10.
Good. Let's take a picture.
Okay.
2 to 5 is exactly right.
Yeah, but look at the lot of
Yeah,
disease.
You'll need another
Pseudo
long
lesions.
stent there.
Pseudo lesion. I think a 38 will cover all the way.
Samin, going back to, despite your underplaying it, the Bangalore and the fight paper, the review, it is provocative, no?
Yeah, absolutely.
You cannot. I think the true purpose of that paper would be more of a hypothesis generating to set up something further, but to extend, the surgeons could almost come back and say that, look, we've had improvement in our techniques which were not incorporated in freedom.
Right, absolutely. It's 2.510. Yeah, no,
No,
that
we-
is no question. I mean, clearly that having a stent thrombosis, which we knew when we were part of the trial, that after 1-2 years, patients started coming back with a stent thrombosis, and so,
We have to talk about our handbook.
yeah.
All
No,
the
once it
technique.
comes, we'll show. We'll
It
now
will
that
be coming
we don't-
out.
Yeah, but then we'll show it by itself.
Okay,
Right?
go up here. No,
Okay.
this I want to talk about the micro crush. The micro,
Yeah.
not the. Okay, go up here.
Go up. Now this is the
This
balloon.
is a 2.5.
Chocolate.
Yeah.
10, 12.
This is a 2.5 is a 2.5.
So
Now
the
maybe
two-
less. Probably it's a 2.5 is a 2.3.
Samin, to me, the advantage look that this grips the lesion a little better, doesn't it?
No, that
No.
definitely.
Right.
But I mean, no, it's the same way like all the atherectomy balloons do. But question here is that it supposed to cause less dissection, but there is no comparison that you have compared this chocolate balloon with a flagstone.
Right.
But idea there is that what can you do, particularly the cases where you don't want to put a stent. I think that will be the one good advantage of this device, and particularly let's say side branch. You don't want to put a stent in the side branch, and so. But definitely will be less slippage. Dilate here.
Go.
Okay, easy to track.
Yeah.
Yeah, we actually just gaining ourselves some experience. This is a 2.5, 10 millimeter, and maximum you can go up to 16. See that little corrugation? Maybe I'll
Down.
just
see
one
it,
second. Yeah. No, let's those chocolate bars.
Right.
Hershey bars, you see it down.
Okay. Now what? You need to go a little further.
No, we are good here. Good.
Good.
Go up here. Done. So what you want? You want to put a 2.538, right?
Yeah,
Into
that's
the
fine.
first,
But
and then
first
we
open
get
this vertical lesion.
this one is a 2.25.
The
12.
same balloon. Same
not
balloon
that.
we'll
I'm
use.
not talking that stent.
Yeah, 2.5.
2.5 12 and
yeah.
a 2.5 38.
Yeah, or 2.7, 538.
No,
So 2.5 is okay. Okay.
Prox.
Yeah.
If you put a 275, will be okay, but then
Yeah.
no, I think it'll plump a lot. Go up here. We just want to make sure that ostium is well expanded. Here.
Samin, which out of all the bifurcation techniques do you think preserves the carina the best?
Depending on how much
The
side,
angle-
depending on
angle
all
is-
the side branch
Right.
lesion, I think the micro crush technique that we are going to show now probably is the best technique to now cover the side branch. Or even if you have a V stenting, if you have large vessel, V stenting is very good.
Picture.
Yeah.
Yeah. The large vessel V stenting, that just 1 or 2 millimeter proximal carina will be extremely useful. That area is more of a soft and pseudo lesion. Good. Okay. Let's go to
But,
the main vessel with this.
No, but what if the plan is to cover it, right?
Yeah. But I don't know that 38 even will cover completely.
Yeah.
We can do the same way, that we can put a 38 up to the main vessel longer. Here. No, let's dilate the main vessel now.
Samin, in some ways, again going to the Bangalore fight paper, the real argument is going to be, does BVS make a difference, no?
Well, that's even
More provocative.
more provocative, but again, to me, BVS still has to prove this better than our
Right.
newer generation
DES.
DES. Yeah,
Right.
Because we saw that clearly. Stent thrombosis 0.3 versus 1 at 1 year. The BVS 1%, current generation 0.3%. Trial after trial have shown that now.
You do a lot of angioplasty outside the country, I know, particularly in India. Have you tried any of the dedicated bifurcation stents?
Well, actually, I've been involved, I would say, in 2 of them. In the live case with the CSI and so, particularly Access Plus.
Right.
Yeah, and there is one more available, but 2 of them. But to me, again, very complex, because Access Plus stent itself, then you put additional 2 or 3 stents. So the Access Plus is the one which people using at present. Go one more. Yeah. Okay.
This is 10, so you can take a 12, right?
Yeah. Yep.
Don't go more
12.
than that.
Yep. This is the 10 millimeter length. 12.
Okay, get us a 2.538 and a 2.512. The only thing is,
And you've decided to leave the circ in the AV groove, the distal lesion
Yeah, that
alone?
Yeah,
I think
that
we
I
leave
think
for the
we'll leave
time
it.
being. If we need to go back, we do it later.
I didn't even go there with the wire. We placed
Right.
it in the other small.
Well, the right coronary artery is such a nice large vessel, which I think covers a part of that territory.
Okay. Now let's decide. Point is your wire has come back. Now
Yeah,
more
we
important
put it
is
like crazy.
yeah. No, but the important here is the decision wise that 38 will not cover your proximal circ going into OM1. 38 will not cover. Let's
Okay.
take one more
No,
picture.
no. Wait, 1 second. Let's do this.
Yeah.
Pull the wire back. Okay. And now
You're
take
going
a
to
picture.
measure that, huh, with the wire?
No measure. I mean, if we think it's pseudo lesion, oh,
Wire has
back.
come back now.
that's okay. Pull back.
Even
I think
distal.
we need to cover it.
Yeah. Right. So if that we need to cover, then should we then put a 38 in the OM and then another long stent in the main vessel, rather than the OM1, because initial plan was OM1 comes to the main vessel and we put a second stent in the distal vessel.
I think that 38 will be too long.
For the main vessel?
No,
The main vessel is
38.
short. And I think more importantly, look at the distal vessel of this distal circ. You need to do a balloon dilatation. See the play? The last one, because it looks a little inflamed now. You want to put see one more picture? You can see this now. It's
So
almost
for
discontinued.
all
Yeah.
of our viewers who thought this was a simple case, here
Put
are
that
2
wire into
experienced
there, push one
interventional
short step, yeah.
cardiologists debating
Yep.
the finer parts of the strategy.
Good. Okay, now the more important is I think we need to take care of the distal vessel. Initially we were thinking that not to do, but that's a very diffusely diseased vessel. Maybe we'll take a better picture now. And if need to, we put a stent now, because clearly a stent through the bifurcation, which you can always go back, but will make a procedure much more complex. So just like we had done one stent in the OM, we need to decide
Get
whether...
that 2O balloon again. But you want a long balloon? That was a 12.
Yeah. No, I would get a 2 or 20 non-compliant. Okay?
You don't need that long.
Yeah.
15.
Ready?
Yeah.
Your wire need to be a little better, because
So
you'll
that's
never
all
know.
you
here.
have it. Cannot go more than
Yeah.
that.
No, here. You need to.
Yeah,
To me, you can
distal
directly
one, no?
go with a stent even.
There's
you
some
want.
calcium, no?
Another
Wait.
2.25.
Don't open.
Yeah.
Give us a 12 balloon.
Yeah.
And get us a 16. No.
Proximal is just a very
No, wire
cut
bars.
plaque. Yeah.
Yeah. 2 to 5.
Okay. Here. So therefore, now we are treating the distal circumflex lesion.
Yes.
Or let's call it for purpose of OM2.
called
OM1,
it
OM2 and
OM2.
proximal circ. Yeah. So we are now putting a 2O12 balloon for the distal for OM2.
Anu, anything different you do for bifurcation lesions so far as the anticoagulant or antiplatelet strategy?
No, we still have angiomax. ACT was 330 and the patient has been on Plavix.
Yeah, in this kind of case, I think if there is an issue with the, I'm going on. Yeah, that using a 2B3A bolus in the end, if some area is just only PTCA will be okay. Because we know that 2B3A has shown consistently one thing, that they will decrease the side branch closure.
Yeah, going back almost 20 years to
Yep.
the EPIC trial, huh?
Yep, that's right. Good.
Yeah, get the stent then.
But question is what length?
Down.
No.
I think 16 should be okay, not 20.
Take
No?
a picture?
Take a picture, yeah.
Okay.
20 will be too long.
Okay,
It'll be like
let's see. Maybe even longer.
2 to 5, 20.
Good, take this out. Because the diffusely diseased segment,
Any particular stent you have found more beneficial in the small vessel sizes?
I think
No,
all-
both are good.
Okay.
Yeah. Okay, now we are putting a 2.25. We put a 2.25 20 in OM1. Now we are putting another 2.25 20 in OM2.
So we have the 2, 5, 38 ready? Good, good. That's good.
Okay, we need to come back a little more,
I
right?
think we are okay.
Good.
Yeah, good. That's
Okay.
Don't go too high. Distal is not.
Yep. 12.
We have posted that. Post.
Yeah. If we need to, we can post dilate. We are any 2.5.
You have 2 to 5. High pressure balloon.
Yeah, that's fine. No, not 20. Shorter. Keep talking also. What's the strategy? What we are doing now? We have put a stent, 2.25 20 now. You saw the distal area did not expand completely. So rather than going with a high pressure and cause dissection and perforation, it's okay to deploy, then come back and take a picture or just dilate first.
So, Samin, here is the gaining popularity of the chocolate balloon. People have found it very interesting as far as Santiago, Dominican Republic, Dr. Aramis Gomez.
Ah,
Bienvenidos.
What they want to do? No, the
They-
recipe of the balloon.
Well, I don't know whether it was your comments or how the balloon interacted, but
why? Yeah. The balloon there, tracked very nicely. Okay.
So this we are going with the post dilation. See, one great thing about Promus is that because of the platinum, you just know where to place if you need a post dilation.
You mean because of the visibility?
Visibility, yeah.
20.
These are 2 to 5. Post dilation went up to 20, and proximally you can go same.
Although proximally nicely expanded,
Yes,
but that's
expanded.
okay.
But I think the vessel tapers down.
Yep.
Down. Now this is very important, especially when you are doing 2 to 5 stent, that you definitely post dilate in the small vessels.
1 second, let's take a picture.
Okay, get us. Now we are going to go 2538 to OM1, depending on how long it covers, then we decide whether we go with a longer stent from the prox circ to the distal. Then distal, how long you want?
It depends. Let's go with the 38 in the OM1 first, then we decide. It depends that whether we making it a mini crescent for the OM2.
Micro-
Clearly, we are looking
Microcrush.
at 4 stents for the case.
Yes. That we knew right from the beginning. The whole question was that could we avoided this third one that in OM2, but we knew that just by having a wire there, and actually this has been shown that just wire in the vessel, particularly diabetic patient, that they come back with a new lesion, even if you have not done any PTCA in that area. So because the presence of wire itself inflames things.
So this is 2538. Good. It's covering. No.
No.
It is.
Almost there.
Almost.
No, but it's covering the OM1, but not the proximal segment.
But then it will be too much of a crush.
Now see.
Mega crush.
Now, other question is that do you leave this some gap, which is okay also. We saw it with the pseudo.
We're covering now. Yeah, the floor. Let me take a cine and see it's covered or not.
You want to pull back and pull?
I think you're just a few millimeters short.
Yeah. No, but it can go a little bit in anyway if we are putting a second stent in the main vessel, in the OM2. So pull back again, you'll go back in again. Yeah. I think we need to cover here, and then we can take a 2.75, 80 is 16 or 20 for the OM2.
Are you connected there?
Now we pull back and maybe let's get the wire into the better area.
You still have a little.
Gap there.
Good.
Good.
Now it went in.
Better. Yeah. Good. Okay, let's get to the main vessel. Decide size-wise.
I think so. You want to go 20,
Yeah.
24.
24.
No,
Or we are
20, maybe we'll be
20
okay.
will be okay.
20 will be okay. But you want a 275?
Yeah. 275/20. So therefore, that's what we are doing. There will be a mini crush at the ostium of the OM1 because the initial plan was to use that maybe from OM1 to the main circumflex, but that's not enough coverage. Now longer stents probably will come in US in a while. As you know, outside US the 48 millimeter is available. That would have been a very good choice. All these Giants, and so they are available in 48 millimeter. Promus Giants.
Outside the US, which is the longest stent available?
I thought it was only 48.
No, I think
Not-
there is a 61
die?
also.
There's 60 also.
Yeah,
Okay, then take a
somewhere
picture.
I've.
No, we see that there's a gap, some die. Yeah.
Good.
This is what? This is the 38?
Yeah. This the.
So now the side branch stent, which is a 2538, I'm just going to pull back. Same, the guide gets sucked in, pull the guide back. Now the main went in, pull the main back again. I think we are okay there with the main.
Okay.
And now the side branch, pull back a little bit more.
Good.
Some dye? I think, let's see.
Yeah, but pull back the main vessel.
No, with some dye.
No, but pull back. Okay.
The main will be okay to adjust. Yeah. This is the main.
Yeah.
Okay. I think we are good now. Right?
Okay. Yeah, you need to adjust because you may not be able to advance the stent after you deploy the stent there.
Too much.
To our viewers, just announcement to share with you the full portfolio of our live cases. The next peripheral interventions case is November 26th, and the next structural heart disease,
Right?
December the 9th.
Okay. Now we are good.
Okay, good. Which one is?
So I think we are good with the placement. We just take a dry cine and then you give some dye. Don't give immediately, okay? First dry. Okay, now go.
Yep, that's fine.
Looks good positioning there.
Yep,
I'm going to go in a little bit with the side.
I would just leave it.
Okay.
Yeah.
Go up with the side. Who has the side? You are the main.
Yeah,
You are the side.
Yep.
So the side branch, which is 2538, will be inflated first.
So Anu, is this the first time in life Samin Sharma became a side?
Yeah.
All right.
Okay. 16.
Ui. Okay, down. Go up again. Now I need a new fielder, okay? This other fielder is, so now what's going to happen is the balloon and the wire, the stent balloon and the wire from the side branch will be taken out. Same, the guide can get sucked in.
Yeah, there is
Pull the
some
guide out a little
controversy,
bit.
Yeah, there was a controversy even in our symposium. Some people say that they
Leave
should
it.
leave the wire. But once you have two-stent approach, leaving the wire may cut the wire sometimes, so that once most of the people will take the wire out once you have two-stent approach.
No, controversy was only one person, but I think
No, other
most of the
people have said,
panel also said that they will take out the side
Right.
branch. Okay.
Most of the people did say. Good. Go up. No, they just go up. Yeah. Go
No
up.
good, no good way.
Take it.
Yeah, that's what I was
Okay, go.
thinking. You'll need
Go
to
up.
come back.
Yep.
This is the 275.
These are 275
20.
for the main. Yeah. Go, 14.
16 or 20 millimeter?
This was 20. Okay. Down. No, take out the whole thing. Oh,
Wire will be okay. Yeah, go up again. Do a little distal massage in this one.
this one should be-
All right, then last will remain. We are getting to our time, and hopefully it looks good. You
Okay,
see
ready?
that clearly
I
crushed
think
there.
it's going to look excellent.
Ready? You see a line, which is with the micro crush. You always see it.
And what do you do with the mid portion there?
I think good medical therapy with vasodilators.
You don't want to just dilate that with the balloon?
No.
Okay.
Which
If you're
one?
not going to stent it, don't
Yeah.
go back and
Right.
do balloon.
Yeah. No, that is true. No, but it looks okay now.
Yeah.
Compared to that distal part of OM2, which will look very inflamed earlier. So let's go with the kissing balloon dilatation. Go now into the OM1 again. You have the wire
But
there.
That-
can you give us a 2512 new balloon?
Samin, that just to remind the viewers is an essential part of the strategy
Yes.
using two stents.
Yes. The dilatation. Good.
Get us a new 2512 you have? Yeah, and then what you want to use here? 275, 15, high pressure.
Okay.
So for the side branch, you go with the compliant balloon, and for the main branch, you go with the non-compliant balloon.
Side
main
branch.
branch.
This is for the side branch.
The side branch, yeah. We are going with the
This one.
2512 compliant balloon, which is a new balloon, but
What's the rationale for using that?
so that it will go
Easy to
cross. Since you have some mini crush, some crushed stent there, so it's easier if you go with the compliant balloon.
Because many times, believe me, I have been on to his live workshops, and they all try to go through it. That try to high pressure, a previously inflated balloon never goes. Never goes. So even this one, compliant balloon, having a tough time. See that?
2.
So now then you go with the 1.512 first. Or maybe again, one thing you can do, you recross.
You have that 2O, right? We had
We
the
had 2O 12?
but we had used it. May
Yeah,
still go.
That's fine. Now, other question is, there is a balloon called glider. Do we have the glider balloon?
We have a glider.
You want to try that? It's a 4 millimeter.
154.
No, yeah, 2.5, 2 4 millimeter.
But how do you know the 2O, the trek, mini trek will not go?
No, but glider will be specifically for these kind of situations.
No, if you want to really try, take a 2.5. Don't take a 2O.
Okay, give 2.5.
Yeah.
Good. Okay. Now this is also trimarine, the glider particularly for the jail side branches, 4 millimeter. We have used actually reasonably with some good success, some not that good success. But now also, I always say that try also, maybe you can go to the different branch, different strut if you have trouble in going. But now we are getting with a 2.5, 4 millimeter, the glider balloon.
Get the mini trek. This is not going to go. Belongs glider. We have a 208.
All right, maintain. That's it. That's it.
Okay.
Don't go beyond.
2.5, right?
Yeah.
Good.
Good. So say, so the compliant balloon 2 or 2.2 compliant balloon was what size?
That
Earlier
was
balloon.
down.
2.5. That did not go and the glider went.
Down.
This
Get us
is
a
a 4
275.
millimeter.
No, but you have to cine this so that people can see. 4 millimeter, very short balloon. Huh? Huh? That's for the main vessel now.
Yeah, first main vessel you place it, then you dilate. First you place it, then you dilate it.
Yeah.
But many times, then this will not go.
27515, yeah. And same that when you are recrossing, make sure you try to put your all the energy and concentrate on recrossing, because then only you put a second balloon in the main vessel. Because once you have multiple balloons and so, there will be so much friction, will be a trouble. The second point is that you could keep both of them, that you could keep both the balloons before you dilate. Because also what we have done with little excitement that we have opened the side branch, but idea should be that you
You cannot open the side branch until you have a balloon in the main vessel.
Because sometimes it may distort it, and your balloon may not able to go or will give you difficulty. Once you have stented, you will always be able to get a balloon. But sometimes it will just give it more difficulty.
So the key is you place both your balloon and then you inflate your side branch. Yeah. No.
You have it, so it will be very good. Okay, now this is a 2.75 15 quantum
Non-compliant going to the
Main.
main. But this is again 1-to-1.
Yep. Good.
So I can bring the glider back.
Yeah.
Okay, now you go.
Go. Although these will slip.
Down. It went out.
How high are you?
No,
I
we
think
didn't go. It
1-to-1
slipped.
you can go your regular 20 atmosphere and so.
Okay.
Okay, go.
Yep. You want to pull back the glider first? Let's open the ostium nicely. Pull back more. Yeah. Good. Pull back the main vessel balloon. Good. Go with the glider. Go. I want to open the ostium nicely. That's 16, 18. 18. Good. Okay. Now let's cine. Negative.
Down. Side branch, many time I think you should go quarter size smaller, but the main branch you always go 1-to-1, non-compliant.
Yep.
Because once you go 1-to-1, many time it slips. The kissing balloon, when you're doing, it will slip. Can I come back here?
Yes,
High
proximally
pressure.
left
Go high
yeah.
pressure.
Yeah. We are in
Yeah.
20.
Okay.
You can
Down.
go 2 atmospheres, not just one thing short. So no plaque shift. 10, 4.
Okay.
Good, negative.
Down.
All right, so we are done to see the main, how things are, and if looks good, we come to the conclusion.
So, I mean, a few questions. I want to emphasize the point came in that look, even before you use the kissing balloon, things looked great, but it is an absolute essential part to be using the kissing balloon technique after the dedicated 2 stents.
Absolutely, absolutely. Because every study of the 2 stent strategy have shown that if you did not do the final kissing balloon inflation, it is possible. Because no matter how expert you are, there will be small percentage, 2-3%, 4% you may not be able to do it. But every attempt should be made, and if you could not do, the chances of stent thrombosis, side branch occlusion, restenosis is 5-fold higher. And that's the key, 5 times higher.
Anu, no need to post-dilate the OM1 in the, the mid part of that stent looks a little underexpanded too.
No, that's what I'm noticing that. Plus, I think this balloon slippage of the main vessel has a little distal up here, but still I think it's everything under acceptable range.
Right.
Yeah.
I mean, you don't have to.
I mean, this pursuit of perfection will come to haunt you.
Yeah.
Okay, yeah, it looks,
Yep.
maybe it's a little angulation too. So, Samin, what are, you want to tackle your questions first?
Exactly, quickly we end up because it looks good. Only question is that do you want to do a little balloon dilatation of the OM2, right? Is that the plan?
No. I am not OM2. I'm worried about the under expansion of the first
OM1.
stent.
Yeah.
OM1.
Good. So we have a 2.75 balloon.
We can just
will
that.
post dilate there. So quickly, two take-home message: update in bifurcation lesion PCI and the revascularization in diabetic. That the bifurcation lesion PCI involving FFR has limited value. Therefore, I would say leave the side branch from FFR. While we do FFR everywhere else, probably based on the DK Class 6, which prospectively evaluated the role of FFR, comes negative, so that no prospective strategy for FFR is there at present for the side branch. But yes, a prospective strategy of identifying complex bifurcation lesion is useful and has better outcomes with the use of 2 stents versus 1 stent. Second, the drug-eluting balloon is inferior to DES in bifurcation lesion, even as the provisional side branch strategy. Second, despite the superior outcome of the cabbage in freedom trial using first generation DES, data are emerging that newer generation DES, especially cobalt chromium, everolimus eluting stent, has potential to have similar outcomes to cabbage in multi-vessel diabetic patient. Of course, the future trials of the revascularization in complex CAD in diabetic patients will be needed for the final answer with the current generation DES. 3 questions following the true statement regarding DK Class 6, that is a higher MACE rate with angio-guided PCI, lower stent thrombosis with FFR-guided PCI, higher overall TVR in angio-guided PCI, higher side branch restenosis in FFR-guided PCI, and lastly the higher MACE rates with angio-guided PCI. We have spoken about this in the DK class. Second, the following is the true statement from the definition study of the bifurcation lesion PCI. MACE rates were similar in simple versus complex group. Outcomes were better with 2-stent strategy versus provisional strategy in complex group. The rates of MI are similar in single versus complex group. Rates of stent thrombosis are similar in similar versus complex group, and it is tough to predict which bifurcation lesion is simple or complex. And the third question, and we have spoken again about the kind of answer for this case. The third is that the mixed treatment comparison analysis of various PCI types, the paper which we have extensively discussed, and the cabbage have shown the following not to be true. 1. Higher mortality with SCS or paclitaxel eluting stent versus cabbage. Higher TVR with PCI versus cabbage. Lower stroke rates with PCI versus cabbage. Higher MI rates with PCI versus cabbage. And PCI with cobalt chromium EES has higher mortality and TVR versus cabbage. Clearly that we have spoken about all, and I always try to bring the very controversial, or more importantly the latest in the data set for the results for the scientific advancement of her points. And we take, Anu had post dilated that OM, and now we are taking a picture, and you can see here looking fantastic.
It's good now.
All looking good. Any further comment?
Anu, any final points from you?
I think I just want to make a point on bifurcation preferred strategy. If we are going to have dedicated two stent, what is a preferred strategy that we would like? When I say when you have a side branch that's large, which is a 275 and larger, and you have significant side branch disease, I think depending on what's the length of your proximal vessel involvement, that's when you decide whether you're going to do the micro crush, mini crush technique that we showed, versus if it is a short proximal area of the main branch, you can decide on the large vessel that you do V stenting or SKS. V stenting is same, is a 2 millimeter carina. If you have more than 2 millimeters, then we call it as a SKS. But we are talking about 275 greater side branch and proximal, main branch, which is a 30 and larger. Otherwise, majority of the cases, the preferred bifurcation stenting at our institution is what we just showed, which is the micro or the mini crush, where you pre-treat both the main vessel, side branch. You do pre-treatment. Usually if there is calcium, you may have to do rotational atherectomy of the main branch and the side branch cutting balloon with whatever cutting balloon that you want to do. Once you have pre-treated it, the stenting would be the same. You place both the stents in the main branch and the side branch, and the most important point I think you need to focus is how much of your side branch stent comes into the main branch, which should not be more than one cell. Should be sticking into the side branch. You dilate the side branch, then you take out your SDS balloon and the side branch wire, dilate then you deploy your main branch stent, and then you recross and kiss, like we showed all the steps here.
And plus, whenever you're using a 2-stent strategy, a 7 French system.
Yeah, the 7 French system would be ideal.
Yeah, some of them they're done with a reverse crush using one side balloon, but they're too complex.
Yeah, the reverse crush is when you have, you wanted to do single stent strategy and your side branch, actually you wanted to stent after PTCA.
Yeah. But overall, clearly that these are the tough cases. But going through the step-by-step technique, hopefully the viewers find it very useful. And we felt that this is one of the very diffusely diseased circumflex with multiple lesions, and going through the various steps was, and we were able to show exactly what we wanted to do in this particular case. We knew about the 4-stent strategy and came out very well, and of course we showed the use of few new devices of the glider and the chocolate balloon.
The other thing also is the wire. I think the wire choice, which everybody, I think we used here the run through in the OM1, and we used the fielder which was in the main vessel. You saw that even recrossing, I was able to recross with run through, but otherwise you can have your fielder in the main vessel. Just take that wire and go to the side branch and use the side branch wire into the main branch, provided the tip is okay. If the tip has been distorted, to get into the side branch, it is easier if you have fielder or whisper to get into the side branch, and just leave your main workhorse wire always in the main branch.
What percentage would you give of any recurrence of disease in this lesion?
Well,
this bifurcation.
Yeah, I would say will be about anywhere between 5 to 10% in some area. Some might come back with the segment which we had left it,
right,
or maybe the distal area in the OM2 after the bifurcation, because from the proximal circumflex going into the OM1 looks excellent. There is some chance of restenosis in this particular case will be in the OM2.
Samin, excellent. Anu, wonderful teaching tips. Congratulations for the entire team who has worked as efficiently as always. I hope the viewers have found it useful. We will see you during session 66, which is on December the 16th.